which is not much talked about since last decade. I think we have started looking mental health as illness, and we went on creating an act, Mental Health Act in 2017, and taking up mental health as a disability also was in the last decade that we did. So the government has become proactive regarding the mental health, and in the recent judgment of 2025, which was Sukhdev Saha versus State of Andhra Pradesh, where we had taken mental health as a fundamental right under Article 21. So Uttarakhand has been considered or looking at the disasters that has been occurring in the state. I would like to ask you, Dr. Rohit, what are the psychological impact of disasters, like the recent disasters? I was reading about Dharali event, like I was discussing it with you too. I read in the newspaper that people were so much traumatized with the disasters that they went to actually went to the disaster site, and what they did was they actually gazed at the site endlessly and they couldn't speak. Some of them had suicidal tendencies because they lost their loved ones. So what are the psychological impacts of disasters?
So, thank you. It is a beautiful question, and many of us doesn't talk about it. Disaster is not only about the economic disruption or the communication. It is also about the mental health well-being. People usually have a lot of emotions, which we have seen in Dharali. I was there on the Dharavali on the next day. I was not able to get many patients, to be true. And many of the patients doesn't wanted to come to the psychiatrist, that knowing that there is a psychiatrist, because they will be labeled as a mental patient, or they will have the problem, that what will the other people will think about them. So that was one of the drawback which I faced. So what I did, I tried to find out the patient among the common people who visited us for cough and cold. They came to us saying that we have a pain in our body, we have this. They have all physical symptoms, but they were not willing to talk about mental symptoms. Later on, when they have been asked a lot, some of them come up. And within 3 days, I think I saw around 40 to 50 patients who have anxiety disorders. These anxiety disorders, they didn't went to the hospital ever. Think, the people doesn't wanted to go to the hospital for the treatment. Sometimes there are lack of services, sometimes there are stigma associated with it. But they don't want to go to the hospital. कौन अपने आप को पागल घोषित करना चाहता है? मेंटल हॉस्पिटल का मतलब पागल घोषित करना है. That's, in my view, mental word is not the right word to say. I think it is more of a psychiatric illness, and हम उसे मनोरोग कहना ज़्यादा पसंद करना चाहूँगा, rather than saying it a mental, which it with a discrimination. And back to the question, when I was there, I saw many patients which were crying. People were trying to find the closure. As the government, SDRF, NDRF was trying to dig up the bodies, but more they are trying to dig, more silt was coming. So it was impossible for them to dig. And many of the families who have lost their family members, they wanted the closure. They wanted to see the body of the family member. कि एटलीस्ट हम रोएं किसके ऊपर, ये तो पता चले कि वो है या नहीं है. वो ही नहीं समझ आ रहा है. एंड दैट सप्रेस्ड इमोशंस, वो उनको नहीं पता चल रहा था कि क्या हो रहा है. वो सोमैटिक कंप्लेन, फिजिकल कंप्लेंट्स में मिल रहा था कि पैर में दर्द हो रहा है, सर में दर्द हो रहा है. जब आपको रात भर यही नींद नहीं आएगी कि मैं रात भर आप यही सोचेंगे कि क्या हुआ क्या हुआ क्या हुआ, मेरे बेटे के साथ में क्या हुआ है या नहीं है, तो आपको फिजिकल सिम्टम्स आएंगे, क्योंकि मेंटल स्ट्रेस इनडायरेक्टली कॉजेज फिजिकल सिम्टम्स. एंड दिस हैपेंड इन धराली. We gave medicines to the patient as we were the first to respond there. We give them medication for 7 days, but after that people were lost. They didn't came to us. I can't say whether it was our fault or whether it's a government fault, but there is something we have left behind. We have left those people there. We need to do more. We have to look for them also now, whether they have problems or not.
Yes, very true. The pain of losing their loved one is far more than the physical impact that they have gone through. Now, I would like to ask Dr. Burman, since you are representing State Mental Health Authority, Uttarakhand has its unique social and geographical challenges. So what are the challenges and gaps that you see in the area of mental health in the state?
Thank you, ma'am. Good evening. I should say, yeah, good afternoon to everybody. मैम ने पूछे कि गैप्स क्या है और चैलेंजेस क्या है. In case of mental health care for the Himalayas, even I should say the whole spectrum of Himalaya, ranging from this Jammu Kashmir to northeast regions of India or Bharat, there is a peculiar silence, a peculiar invisibility. That invisibility is not, that invisibility didn't cropped up for the mountains, heights of the mountains or the ridges of the mountains, but something else. And Uttarakhand has tried to sort out to some sort of, I should say, we tried to bring out the evidence, the hard evidence. What is the load in mental health issues in Uttarakhand? So last year we had a survey, and that was done by NIMHANS Bangalore in collaboration with Doon Medical College and SMH Uttarakhand. We got 35,000 plus adolescents and children, only adolescents and children, excluding adults, in case of autism spectrum disorder, intellectual disability, and specific learning disorders, along with common mental disorders. Here, we are excluding the severe mental disorders. So only this thing counts for about 35,000 plus children and adolescents who are suffering. The report has come out last year, and this was the first of its kind in India, this type of survey done by a state. So accordingly, we are going to plan our policy directions and all those things we are going to plan, because this is itself, I should say that this is one of the major gap. Once we follow, once we try to cover the gap, bridge the gap or bridge the gulf, bridge the ridge through our, through technology, through awareness generations, through destigmatizations of mental health disorders, we can move forward.
Definitely. Like you mentioned, Dr. Rohit, people who reach you out are labeled as mental. So I think that tag and that label is still a stigma in societies. Especially in context of hill states, there are certain superstitious or religious practices associated. You know, you cannot differentiate between if a person has some mental issues or if they have their religious practices. And while we reach out the communities, how do you differentiate and how do you approach people and communities in such cases without hampering their religious practices?
Religious is important, actually, and religious practices are also important. अगर हमारी religious practice नहीं होगी तो हमारे पे hope नहीं होगी. मतलब कुछ लोग कहते हैं भगवान होना ज़रूरी नहीं है, कुछ लोग कहते हैं कि भगवान होना ज़रूरी है. मैं ये कहता हूँ आपको जो अच्छा लगता है वो होना ज़रूरी है, चाहे वो भगवान हो या ना हो, बस आपके पास होप होनी ज़रूरी है. वो बहुत ज़रूरी है. जो रिलीजियस है वो आपको होप देता है. और जब आप साइकाट्री की बात कर रहे हो, साइकाट्री रिलीजियस हर चीज़ के ऊपर उठ के बात करता है, कहते हैं नहीं ये एक पेशेंट है, दिस इज़ अ पेशेंट एंड वी शुड ट्रीट हिम लाइक अ पेशेंट. चाहे वो पोजेशन हो जिसे हम देवी देवता कहते हैं, चाहे वो स्किज़ोफ्रेनिया में जिसमें साइकोसिस हो जिसमें आवाज़ें सुनाई देती हैं, वी ट्रीट इट एज अ डिसऑर्डर. बट जब पेशेंट हमारे पास आता है, व्हाट आई यूजुअली डू एंड व्हाट माय प्रोफेसर्स टोल्ड मी टू डू, मेक अ गैप, आस्क देम आपने अपनी रिलीजियस प्रैक्टिसेस पूरी कर ली है, देन इट्स फाइन. इफ़ यू वांट टू डू एनीथिंग मोर, आप वो भी कर लीजिए, बट देन आई विल स्टार्ट माई ट्रीटमेंट. क्योंकि ना अब मैं ट्रीटमेंट शुरू करूँगा, फिर आपकी रिलीजियस प्रैक्टिस होगी, देन यू विल नॉट बी एबल टू डिफरेंशिएट कि पेशेंट को ट्रीटमेंट कहाँ से मिला और पेशेंट ठीक कहाँ से हुआ. वहाँ पे वो गैप क्रिएट हो जाएगा. सेकेंड थिंग ये है कि हम लोग मोस्टली, अगर अभी जो आपने मेरे से लास्ट क्वेश्चन पूछा था उसमें मैं अब दो बातें मिस कर गया. पहला, हम लोगों ने ना वुमेन मिस कर चुके हैं हम लोग. डिज़ास्टर, जब धराली में डिज़ास्टर हुआ, वी डिडंट लुक टुवर्ड्स द वुमेन, वी वर नॉट एबल टू. मेल्स तो फिर भी आ गए नीचे क्योंकि मेल्स कम्युनिटी सारा डोमिनेंट है. दैट्स वाई हिमालयन रीजन में मेल्स आ जाते हैं घूमते फिरते, वो घूमते फिरते दवाई लेने के लिए पहुंच जाते हैं, बट फीमेल्स नहीं आती हैं. हम लोगों को वहाँ पे रीच करना पड़ा, ऊपर जाकर वहाँ पर देखना पड़ा. वी फाइंड आउट फीमेल्स वॉज क्राइंग, दे वर क्राइंग अ लॉट. वो पूरी रात भर रो रही हैं, उन्हें कोई देखने वाला नहीं है, वो रो रही हैं, बेहोश हो रही हैं, रो रही हैं. दिस इज़ ऑल गोइंग ऑन. जब जाके उन्हें मेडिकेशन दिया गया तब जाके वो ठीक हुई. वहीं जब बच्चों का था, आज बच्चों के बारे में आपको नहीं पता चल पाएगा क्योंकि बच्चे खेल रहे हैं. द इम्पैक्ट विल बी लॉन्ग लास्टिंग ऑन द चिल्ड्रंस. आपको वो भी ध्यान रखना है कि क्योंकि जैसे धराली में एक डिज़ास्टर हुआ तो बहुत बच्चों के स्कूल चले गए, कुछ के फ्रेंड्स का पता नहीं चला, सब लोग अलग अलग हो गए. तो दैट लॉस ऑफ फ्रेंड्स, लॉस ऑफ द पीयर ग्रुप, that impacts a child and it impacts a child trust on his friends, trust on his peer groups.
My last question to you both would be, since I am working in the area of public policy at Setu Ayog, so I see everything from the policy lens. So I would like to know from both of you, what policy interventions do we need at present to improve the mental health status of the civilians of the state, especially in a state like Uttarakhand?
Sir, ma'am, actually what I believe is, India in 2017 has developed such a progressive, and I should say the most advanced rules or laws, not rules, sorry, laws that is in mental health care, that is Mental Health Care Act 2017. That is basically like nobody, and the strange thing was in the study of by Nimans and Doon Medical College and ours, was that nobody, not a single person was aware of this Mental Health Care Act. Just imagine the magnitude of awareness, lack of awareness, I should say. Because Mental Health Care Act gives us, every citizen of India, the right, like RTI, right to information, that we all know. We use this RTI to move the system. Now it is time we should use this Mental Health Care Act 2017 to move the mental health care system in India, so that we can give a resilient India, a demographically healthy India, not only by physical health, but by mental health also, so that we can move towards Vikshit Bharat. And really Vikshit, through our intent, through our action, and through our reach.
Thank you, sir. I want to add few more things to it. As we have already been having many policies, many things which are working for the psychiatric patient, like Tele-MANAS, e-Sanjeevani, e-Manas, many things are there. But the problem is that it's not, we haven't done IEC activities. We haven't provided the information to the people. We haven't told them that Tele-MANAS, something psychiatric thing, does exist. Someone is there to hear you. We don't know that. How many of you do know that there is a number called Tele-MANAS, which is for psychiatric illnesses and psychological treatment? And I can see only 5 to 7 hands there. 14416 is the number. It is throughout India. And it is the free of cost place where counselors are available to help you out. And we don't know that. Why we are not there? Because we haven't done any IEC activity yet. A program which is there by the central government, running in each state, and still we are not able to tell it to every person now. Second thing which lastly, I just wanted to incorporate 2 points, that in disaster-prone areas, we need some teams, psychological assessment teams, which can be made, which can help for the patient who are there in distress, and these team can help the Tele-MANAS people also. That when there is a person who wanted to commit a suicide, We get a call. I am a Tele-MANAS nodal officer at State Mental Hospital. We get a call from a patient who is sitting in Almora that I want to die at around 2 a.m. in the morning. I want to die now. I have done everything. I have put the rope on the fan and I have made a loop. Now I just wanted to die. And we have no one to help him, how to stop him. Last time we talked to him till 11 a.m. just to take him to the hospital, just to manage him by somehow to take to the hospital. No one was willing to help us. Police doesn't know 14416. No one was there to help us. This is the thing we have to improve. We have to improve everything about psychiatry. We have to tell everyone so that people can help each other. And that's why we will be able to we will be able to decrease the suicide rate. We will be able to decrease the mental illnesses.
Yes,
So
very
that's
true,
all.
sir. Sometimes people need to be heard. In a competitive world where we have so many people around us on social media, but we don't have anyone to hear us out. So I think Tele-MANAS is doing a pretty good job in that context. I think Burman sir would...
I'll give the last, because bazaar shayad baj gaya.
Definitely,
No
we are
issue.
running short
I'll
of
not
time.
stretch it. Just the last thing to tell about Uttarakhand. Actually, State Mental Health Authority is already in touch with NIMANS Bangalore. We are basically creating the ecosystem of mental health care through digital platform. And that is known as, later on I'll speak about details after this session finishes. I'm only going by the name of the platform. That is integrated tired care, or you can say theater care model of mental health care in Uttarakhand. Integrated in the sense that there are 3 verticals. They are all will be integrated. One is Tele-MANAS. Second one is Man Sangbad AI. Third one is E-MANAS. So all the 3 parameters will be taken care of. Governance, mental health care governance, mental health care services, and mental health care self-screening through AI, through stigma-free in a household, in a remote village mode places also that can be done through the application of AI. Man Sangbad, we are doing that. Thank you.
Thank you so much, sir. Thank you.